Hello, I'm Patrick Dunn, and with me today is Carl Hinkson. Carl is a director of the Pulmonary Service Line at Providence Regional Medical Center, located in Everett, Washington. Carl, glad you could join us.
Thank you, Patrick.
We're going to begin, the whole purpose of this is to talk about how you and your staff reacted to the challenges that were unleashed on us, the unprecedented challenges with the COVID-19 pandemic. And we were chatting briefly earlier, and you mentioned that your hospital is rather infamous in certain respects in terms of the diagnosis of the first patient with COVID-19. Could you elaborate on that just a bit?
Yeah, so back in January, my facility had the first diagnosed patients with COVID-19 in the United States. The patient had been in the Wuhan province, had returned to the United States, and began having symptoms, and they recognized that they were having symptoms and self-reported. So we assessed the patient in our special infectious unit, and then they were discharged. So we had the first patient in the United States with COVID-19, first diagnosed and confirmed patients.
But certainly not the last, because for a while, Washington was ground zero for the increase in the COVID-19, especially in the last 2, 3, 4 months right after January.
That is correct. So for me, we had that first patient, and we at that time felt or thought that the spread of the disease was pretty self-contained. Providence in Everett is an assessment center, so we would assess the patients, and if they escalated to critical care, then they would have been transferred to another facility. That changed several weeks later. I was called into the office by my boss, and he had discussed with me that the strategy was changing, that Providence and Everett would then become a treatment center for COVID-19.
That's a complete departure from what you had previous to that conversation, I would imagine.
Yeah, the respiratory therapy department had not handled highly infectious diseases like an Ebola or a SARS outbreak in the past. So we hadn't really taken care of anything more infectious than, say, a tuberculosis patient.
So you had an emergency preparedness plan in place, like most hospitals, like all hospitals, which were primarily designed prior to COVID for a one-time event. Now, all of a sudden, you have an ongoing crisis, and we don't even know where it's going to end. How did that change the operation of your department within the hospital hierarchy?
Well, I think at first, when I first learned about that we would be changing our strategy, my first action item was to meet with the RT staff and to inform them of this change. I had known from some of my previous experience that it would be best to have this conversation so that they could prepare themselves. So I called an impromptu meeting with the staff and told them that there was a real possibility that we would be treating patients for COVID-19 on the acute care floors and in the ICUs. And that there would be some just-in-time training on how to do the PPE and the level of donning and doffing that would be required to care for these patients. And that training was actually just being set up as I was telling them, and then we directed them to those areas, to those training sessions.
Now you got involved in a larger capacity with the hospital's orientation with this incident command center that we talked about. Why don't you briefly describe how you got involved to that degree?
So the hospital had seen fit to send me to the Centers for Disease Control has a healthcare incident command training course in Anniston, Alabama. And because part of my responsibilities, my job currently is to rotate hospital administrator on call, they sponsored me to go to Anniston, Alabama and participate in that training. And what that training entails is teaching people how to run a hospital incident command should a disaster arise. So I was familiar with what they call the hospital incident command structure, or HIC structure. And as the surge in the pandemic progressed, I started taking turns as the incident commander for the hospital. And so there were several weekends in a row and several days where I was serving as the hospital incident commander.
Now, part of this responsibility for the RT service line was also to increase your resources, both human as well as mechanical. You needed ventilators, you needed PPP equipment that you didn't have. I don't want to say how do you get to the head of the line, but how did you justify the respiratory care service line ahead of, say, outpatient or laboratory? Or everybody had an argument to be made, but obviously you folks got the resources you needed rather quickly.
In any disaster, I've always been taught it's space, staff, and stuff. Really kind of simple phrase, but it helps me to envision what it is I need to do. So as we started to surge, we started looking at ordering supplies, increasing those items that we knew could be used frequently. One of them was PPE, of course. Everyone became very hyper aware of how important PPE was. And we targeted the patients who were doing the direct patient care in those areas as the main users of PPE, and sort of triaged it from there. So as the surge sort of continued on, we didn't shut down outpatient services right away, but it became obvious that the surge was going to be substantial. We started limiting our other procedures. We eventually shut down all the elective procedures, and part of that was not only to keep healthy people out of the hospital, but it was also to preserve our PPE.
And redeploy staff to address the looming staff shortage, right? We'll talk more about that in a moment. One of the elements that came out of this whole area of COVID-19, which I believe was relatively innocuous going into this, were what we now call aerosol generating medical procedures, such as intubation, extubation, open airway suctioning. How did you deal with that change in philosophy and convince your staff and the other healthcare workers, the doctors, nurses, and aides, that this is no longer an innocuous procedure?
As we started discussing with infection prevention that certain what we were calling levels of PPE that we would use for particular patients, we knew that there would probably be some aerosolizing generator procedures that could heighten the risk to the caregivers. And this came from my previous experience during the H1N1 crisis, during what my understanding during the SARS outbreak. And so I met with my medical director. We created a list of the procedures that we felt would be considered aerosolizing generating, circulated that list to our infection prevention folks, and they then approved it, and then we distributed that to the staff, to the house-wide, as these were would be considered aerosolizing generators procedures. And if you were doing an aerosolizing generating procedure, you would have to do the N95 and what we call the capper. Some people have PAPRs, but we had the cap version of it. And then we kind of disseminated that information, and was also being Providence is a part of a large system that communicates with each other. We distributed that list into the what we call the Respiratory Therapy Resource Council, and they fine-tuned the list, and we distributed that to the other other facilities. I'm sorry, in Providence, other hospitals are called ministries.
So essentially, you're basically using best practices and disseminating it through an established chain of communication with other facilities, which is kind of very unprecedented, but very necessary here to kind of share what you learned with your colleagues in other parts of the country.
Yes.
With regard to the aerosol generating procedures, what I didn't mention was actually administering aerosolized medications for patients who have a medical need, medical necessity. And I've read in the literature, one of the first things that people argue is you want to avoid unnecessary treatments, which I have a trouble with myself, because if they're unnecessary, why are they provided and why are we doing it? How did you address the fact that now we have patients who do need aerosol medication delivery, which even heightens the risk to the provider?
Well, what we did here is we kind of pivoted some of our strategies. Generally, we were using nebulizers as a frontline treatment in our emergency department, but recognizing that this could put the caregivers at risk and increase our usage of PPE, what we did is we started having the physicians ordered meter dose inhalers, the inhalers for the patients instead of using the nebulizers, to make sure that if the patient could use the MDI, then they could use that. We had patients who still could not use a meter dose inhaler. And for those patients, we reserved the nebulizer for, and in those patients, if we had to do that in the airborne precautions, we gave them the breath actuated nebulizer. Again, the breath actuated nebulizer only makes aerosol when the patient's breathing in. So that has the benefit of less medicine being aerosolized into the room, less chance of cross-contamination, still another level of safety for the caregivers at the bedside.
How did you determine if a prescribed procedure out on the floor, for example, was indeed medically necessary? Did you have protocols in place, or how, again, not undermining physicians, but sometimes those treatments might just be for the patient needs to see somebody, or the respiratory therapist is who they like. And again, all good reasons, but in your case, certainly not acceptable.
Yeah, we have a respiratory therapy assess and treat protocol, which allows the respiratory therapist to make an assessment and make a therapy plan based upon the assessment that they do. That is helpful in eliminating and limiting unnecessary therapy. And we were very proactive during that. And we had a lot of help from pharmacy and from nurses and physicians in helping us try to limit some of that unnecessary therapy during this crisis. Because, like I said, it's all during a disaster, space, staff, and stuff. Even medicine becomes a precious commodity in this. As we started using more metered dose inhalers, we needed to be very mindful of our stock on those.
Mm-hmm. Mm-hmm. Now, when you talk about aerosol generating procedures, we also mention aerosol therapy. What about the patients who came in who had a very good track record with their maintenance medications for their COPD or for their asthma, and yet they also had a COVID-19 episode? How did you handle those particular patients? You had two things to deal with: maintaining control of the prior disease, at the same time treating the acute onset of a newer disease.
Well, we had to make those assessments on a patient-by-patient basis. A lot of the patients, depending upon their age and how they were doing, would dictate how we, manage their medications. The less acute ones, we would try and maintain as much of their therapy medicine as we could. And for those sicker ones, we had to escalate the care into other areas. Mm-hmm. Non-invasive ventilation, high flow nasal cannulas. We were very hesitant to use those therapies early on. And I think as we learned about COVID-19, we became less hesitant to use some of those less invasive therapies for these patient populations.
You raise an interesting point that is very controversial, and that is because this is a worldwide episode, we have information coming onto the internet much, much faster than the traditional way of submitting a manuscript and getting it peer reviewed. Sometimes takes 10 to 12 months before it sees the light of day. Here you're making changes on data that's probably somewhat anecdotal, but yet is proven to be effective. How did you staff handle the fact you approved a program 2 weeks ago, now all of a sudden we're going to change it?
Well, it wasn't even 2 weeks ago. Sometimes it was daily. Mm-hmm. I think one of the things that really impressed me about the respiratory therapy department and how the respiratory therapists handled this was sort of the mental flexibility that they adopted during this crisis. We were making changes and decisions. It's, when I say almost daily, it did feel like at times we were making decisions based upon supplies, based upon new learnings, almost on a daily basis. And so we have a daily shift huddle. We would give the updates at the shift huddle, and the therapist just became very adaptive to, okay, what do I got to do today to get through this? And they were understanding the magnitude of the nuances of this, if this was new. And so in some ways we were just kind of learning as we went.
Someone once said, I think in a program I saw you on earlier, where it's kind of like driving on the highway you're trying to build at the same time. It completely changes the dynamic.
I think the analogy I've heard once I thought was kind of adequate or appropriate for this was you're sort of like learning how to build a boat while you're already in the water.
Right. Mm-hmm.
And certainly we were doing that.
Well, resiliency and nimbleness were certainly characteristics you needed. How about the any pushback, or I should say it in a positive way, a lot of the people that were brought into the intensive care unit, physicians and nurses, really did not have ICU experience for several years because of their new position in outpatient or working outside. And now they're being brought into an intensive care, and they're asking the respiratory therapist to help train them on hopefully what not to do with ventilators. How did your staff respond? Some therapists took umbrage with that, let's be fair.
Well, one of the fortunate things with being first in the surge is that we ramped up our staffing very quickly. So we didn't get to the point to where we actually had to use respiratory therapy extenders. The staff were very open to the idea if the staffing ratios got bad. And our plan here in Everett was to use the nurse anesthetists as respiratory therapy extenders. We had a couple reasons for this. One, they were the ones that were most familiar with mechanical ventilation. Many of them were previously ICU nurses, now working in the OR. They understood the principles of mechanical ventilation, maybe not lung protective ventilation, but they understood the principles of mechanical ventilation. And so they would be probably a great group to utilize as an RT extender if it came to that. The other reason to use them is, as we shut all the elective surgeries down, they were no longer utilizing their skills. They now had free time. They were free to be redeployed.
Mm-hmm. And they were welcoming, I would imagine it's a great opportunity, first of all, because their primary occupation is not going to be around for a while. They're being redeployed, which I think is what you mentioned earlier about incident command decisions that you make.
Yeah, they were open to the idea. They were looking, if everyone was sort of a hands-on deck attitude, and if this was the manner in which they could help us out, they were more than willing to do that, which I'm appreciative of.
Now, what kind of a legacy has this left? Here you have two disparate organizations, the anesthetists who never come out of the OR, not to be unkind, and the respiratory therapists who never go into the OR. And now all of a sudden, they're compadres. How is that handled going forward? What has it left in terms of a legacy as you see it?
Going forward, it should have a level of mutual respect for each other, understanding that each of us has our own field of knowledge and our own field of experience, and what we bring to the table. We may work in different settings, and that brings some nuances to the care that we provide, but there's still, between both groups and all the groups working in the intensive care unit, a high level of knowledge that you have to bring to bear to care for patients.
When we were talking earlier, one of the comments that struck my attention was you had to do some outside the box thinking and acting to sometimes address your shortages. And you mentioned 3D printers. You even considered going down that route.
Yeah.
How far did you go with that outside the box thinking to try and access the necessary resources you needed?
So we always trying to think 2 steps ahead. And this is how I've always kind of thought about disasters, is you may have the supply now, but what about tomorrow? So you need to be thinking a couple steps ahead. What am I going to do when this supply runs out? Some of the items that we were considering was figuring out how to reprocess our ventilator circuits and reprocess some of the ventilator parts. But another opportunity came to us is one of the universities here in Washington, Washington State University had an engineering program. They reached out to us through the medical school and asked if they could help, and I brought forth the idea, what if we needed to 3D print ventilator parts? How would that work? And we got a pretty good, pretty far into the conversation. They're located out in Spokane, and there's my colleagues at a college out there, Christian Striganow, they actually, I think, got as far as to testing some of their prototypes. They have an ASL test lung out there, so they were doing some testing, I think. And then the crisis sort of passed a little bit for us. So the needs sort of dropped. But I know in other areas there's been some serious looking at, okay, if we run out, can we create a sort of open source program to 3D print items that may be necessary? Now, we saw a lot of secondhand manufacture of PPE. There was a local company, Halyard, I believe it's Halyard, that started making masks for us here at Prov Everett. Boeing was very helpful in trying to help us manufacture face shields. And I know that there are other companies that were across the United States that pivoted their manufacture to PPE. Rogue Fitness, very famous for making fitness equipment, started making face shields for Ohio State University.
Well,
So
one of the other elements that people talked about was the ventilator shortage. Did you ever have to access the ventilator stockpile?
I had at the highest of my ventilator census, we almost reached our full capacity, and we did make the request for extra ventilators. We were projecting, still at that point, we were projecting a pretty significant surge. And so I had asked for access to the stockpile. Many of my local colleagues at the Seattle area and Washington State hospitals were asking how to access it. We did get access to some of the ventilators for a brief period of time, but by the time we got them, our surge seemed to be subsiding, and those ventilators were redeployed to New York.
But you also, I think, got away from intubation quickly and started looking at high flow nasal cannula sooner than later. So it kind of mitigated the need for all those extra ventilators. Is that correct?
Yeah, because we learned about COVID-19, we did not reflexively intubate as quickly as we were.
And the other problem was, of course, with the COVID codes, resuscitation. That's another one of those aerosol generating procedures. How did the RT get involved with involving themselves with the code responses for patients who did experience a cardiac arrest?
One of the hats I wear here is co-chair of the Code Blue Committee. So we had published some guidelines for the hospital on responding to Code Blues pretty early on, I think during the first week of the surge. So
you basically now recognize that this is multidisciplinary. It sounds like you have many, many different sources that you're working with and integrating all this information.
Every time we made a policy decision, we did not make these decisions in silos. We tried to vet it with the various groups, infection prevention, supply chain, to make sure that we weren't creating, as we tried to fix one item, we create chaos in another area. We were trying to work every time as a team.
Now, how about airway clearance therapy for patients who did have, in addition to everything else, a secretion clearance issue? And now we're involving with an aerosol generating medical procedure, but at the same time, it's a very heavy challenge to not address.
For those patients that had airway clearance issues, we didn't deviate too far from, I think, what would be the accepted, standards. If they needed percussive therapy, they got percussive therapy. If they needed nebulizers, they got nebulizers. What would change would be our level of protection for those patients. So if they weren't receiving any aerosolized generating procedures, those patients were in droplet precautions. If they got aerosolizing generating procedures, then that would put them in airborne precautions. And that information was tracked all the way through incident command, where they were aware of which patients were receiving aerosol generating procedures so that they knew what level of protection each patient needed.
So your airway clearance therapies were basically, like you said, titrated to the patient's particular need, and you kind of went up and down, escalation, de-escalation based upon the therapy that was used. What was the most prominent airway clearance therapy that you think you used during the course of the last 3 to 4 months?
Oh, I would say that we stuck with the aerobica.
Mm-hmm. And that's the oscillatory positive expiratory pressure. Patient-friendly, patient is obviously cooperative.
Yes.
And you try and minimize the amount of people going into the room, I would imagine, and encourage self-administration of that therapy. How did that work?
How that worked was the therapist would often instruct the patient and try to self-direct the patient, and then the nurse would encourage the patient as well. Sometimes we would limit our exposure into the room as long as the patient was self-directed.
So it's all about trying to maintain distance at the same time, not deny care, go into the room, but do multiple procedures rather than just one at a time.
Correct.
That's what you're saying. What about proning? I assume your RTs were very much involved in the proning of patients who required it. Here we're now acting as physical therapists, but at the same time, the physicians are there and the nurses are there, and we should be there, especially if they're on a ventilator.
For the intensive care unit, it was a learning experience for, I think, a lot of my executive leadership to learn how involved respiratory therapy actually was in critical care. There was a lot of people who were surprised by the amount of time respiratory therapy was spending in the room assisting with procedures like proning. Proning was something that we had done prior to COVID. It is one of our mainstay rescue maneuvers for refractory hypoxemia. So the only difference was now the therapist is doing it in a lot of PPE as opposed to before.
Yeah, I did some research on your background. You were also a very early advocate, along with your physicians, of ambulating patients soon after surgery to try and reduce the incidence of postoperative pulmonary complications in that regard. So you have experience in some of these before COVID came along and allow you to leverage it to the next level.
Yes.
That's good. Now, look, if you look back on the last 3 to 4 months, you've all mentioned a couple of things, but I want to kind of maybe summarize. What are you most proud of in terms of how your RT staff emerged from this entire challenge? And it's still an ongoing challenge for all intents and purposes.
Yeah, I think one of the things that I'm most proud of is how hard they worked. They were very much in it for the patients. They were in it to win it. They worked very hard. In many instances, they were just very resilient. They just needed to know what the changes were, worked hard to get them done, didn't complain. There was a lot of groups that were focused on sort of extraneous issues, but the RT group was just, they were focused on the patients, doing great patient care and trying to rescue as many people as they could.
Yeah, and I can imagine that this also developed a sense of camaraderie with our co-workers that are not respiratory therapists, the physicians and the nurses and the nursing assistants, probably the pharmacists. You mentioned the pharmacist early on about your conservation of your resources. So it sounds like there's a whole new way of looking at the respiratory care service line at your facility.
I think it is fair to say that respiratory therapy as a whole sort of has a increased profile after this pandemic.
Mm-hmm. Silver lining of a cloud, I guess, is one way to look at it.
Yeah. I think, oftentimes in my career, I sort of self-manage the ventilator fleet. And if we were running low on ventilators, you would rent or ask other facilities if you could borrow a ventilator. And a lot of that work, I think, was invisible to executive leadership. And I would say definitely after this, they had our ventilator fleet and management of that ventilator fleet has their full attention.
How big is your department in terms of FTEs, if you don't mind me asking?
We've got about 55 FTEs in the department, which translates to about 75 therapists.
And all of them were on board. It just sounds like a great team building experience in a positive way. I'm looking at all the positive outcomes here instead of all the negative. And I guess that must make you feel pretty good that your associate leaders, those other people who work with you in managing the RT department, sounds like you didn't have any trouble delegating to them when you were doing your incident command work.
They were great. The therapists were great. When I was doing the incident command, if they needed something specific, they would let me know, but they were absolutely fantastic in trying to manage the patients and the workload.
One of the, finish up here, one of the tidbits that I've been listening to is that there is now some strong suspicion that COVID-19, once it is, quote, person's out of the woods, so to speak, not cured, but certainly out of the woods, there's some lasting damage that we might have a whole new area of chronic lung disease down the road that will require respiratory therapy attention. We don't know what that's going to be like right now, but the suspicion is that it's not an innocuous virus that just goes away when it's treated, but it does have some permanent lasting damage to people who normally were not smokers, but also smokers. Have you folks talked about that potential increase in your chronic lung disease patients down the road?
I don't think we've had any specific conversations about this, about that particular topic. What we do have is a pulmonary rehab program here in Everett, and we're big advocates for the pulmonary rehab program, and we worked really hard to make that open that up again for the community. So it is open now. We had to redesign the program so that we could implement it with good social distancing. But that is something that if that is what happens, if there is some impact on lung function afterwards, I think we are able to
have the resource. You already have the resource in place like you had before, which is nice. It's always nice to look back and say we did the right thing for the right reason.
Right.
Thank you very much, Carl, for being such a gracious and informative guest. We learned quite a bit about how you and your staff, and for all purposes, reinvented how respiratory care services are provided, and also how the roles and responsibilities at Everett are basically understood. And I think that's a great legacy to have. And I want you to thank again and congratulate your staff for a job well done. And thanks for spending time with us to share with us what you've been through. It was no easy task, I'm sure.
Thank you, Patrick.